March and April. So welcome.
Got it. I have to.
Yeah, I'll pass it off to you, Maria. You can take it away.
I have to be careful with what I say, I guess. Okay. So I kind of geared it towards like, I guess more of a larger group, but totally okay to do this with a smaller group as well. As you know, I'm one of the PGY ones. I am very fresh in radiology because we were all off service essentially in first year. So very close to the stage where you guys are at in your training. So my knowledge base with regards to like radiographs, differentials, etc., might not be as vast as like some of my colleagues that you probably listen to the lectures to, like Lucy and Alex. I think they did them, or the staff. They're fantastic. But I think my main goal to you is to sort of give you, I guess, more tangible skills that you can use in your clinical rotations and in residency, as opposed to sort of throwing information at you with like differentials, because I think I'm not there yet. So yeah, let me share my screen. I prepared like a little PowerPoint. Oh God, okay. Pardon all my memes. Okay, you guys can see this?
Yep.
Okay, perfect.
We can see it.
Amazing. Okay. Why isn't it letting me switch slides? Okay, there you go. So my objectives for you guys to do today for these two cases are to be able to understand normal anatomy on a chest radiograph, which I'm sure you probably know, but just to hammer it down, mostly because like sometimes you look at it and you're like, yeah, I think I know what that is, but do I really know what that is? Probably not. Be able to localize the abnormality on a chest x-ray and then describe what pulmonary lesions look like. So basically give you some tools in your descriptive toolbox to be able to describe a chest x-ray if you need to do that during medical school or residency. And I kind of prepared a little quiz. So if you guys want to go on to Menti, or you can just QR code that. And then I'll go on to Menti as well. Give me a second. I need to like change sharing screens. God, there you go. 1 second. Nope, there you go. No. Okay. Are you guys on this? Too. Awesome. Okay, good enough. All right. So, oh, I don't think this through. Well, we're gonna have to kind of double share screens. Wow, that's silly of me. Okay. Can you see this? Are you seeing the chest x-ray?
Yes.
Yes.
Okay,
Yeah, we
perfect.
can see it.
So I'll give you 2 seconds to look at it, and then I'll flip back to the other thing. That was really silly of me. Okay. Go ahead. I hope it works. I've never used Menti before. Yeah, very, very correct. That is the left ventricle. I'll kind of move on to the next one and then we'll bounce through the anatomy. What is this pointing to? Give 2 seconds to look at it and then I'll flip back. Be able to move on to the next one. Hold on. Awesome. You guys are good. Probably don't even need to do this lecture. Okay, next one. Might be a bit vague with the arrow. Let me know if you want me to go back to the slide.
Did you go back to the slide, please?
Yeah. Oh, did I go back to it? No, I didn't. Oh, and yes, I
You
did.
did. Yeah, we can see it.
Okay. Oh, ignore that. That was not supposed to switch. Okay, I see left main bronchus. So this one's a bit more tricky. If you look, I'll go through the anatomy again a bit later, but for this one specifically, if you look at this is the trachea coming down, right? You have your right main bronchus, and then you have your left main bronchus. The right is a little bit kind of higher over here. But then the left, if you look really closely, you can see that it splits into two. So this is your left upper lobe bronchus, and then it splits into the left bronchus intermedius, which is then going to subsequently split into your lingular and then your left lower lobe bronchi that are feeding these two parts of the left lung. So this is actually the left bronchus intermedius. Okay, next one. Switch to the slide. That's correct. That's the retrosternal space. Awesome. What is this? I hope the arrows are clear. Yeah, so this one is also kind of tricky if you don't know the nuances. So we have, if you look closely, there's two. Can you see my mouse, by the way?
We can, yeah.
Okay, awesome. So there's your diaphragms right over here, right? You have 1 and 2. So the left diaphragm actually goes and stops at the level of the heart and then doesn't continue further. The right diaphragm, however, continues all the way through up to like it essentially makes contact with the anterior body wall. So it's always that the right diaphragm is the one that you can see in its entirety, and the left diaphragm is actually the one that stops right at the heart. Didn't know that before. And I guess
Sorry, quick question about that. So
what's up?
it doesn't matter which direction you're looking from, it's always going to be the right one stopping before the heart?
Essentially, sorry, the left one. The left
okay.
one stops, yeah, essentially.
Okay.
Yeah.
Sorry, another question is that for diaphragms, we're told usually that the right side is higher than the left due to the fact that there's liver present in there. So in this case, it appears that the left side is actually a little bit higher than the right side.
Yeah, it does.
In that case, okay.
I think it's mostly projectional. Honestly, I'm not gonna lie, I'm not entirely sure, but I know that the right one, it is higher, that's correct. But the right one does extend on the lateral X-ray all the way through, whereas the left one stops at the heart. Watch me be completely wrong, but yes. But it is on the frontal view, the right one is higher than the left. That's correct. Okay, and last question. This one I think is the trickiest of them all. What do we have? Okay. Yeah, what the hell are you pointing to? Honestly, lateral radiographs, even now, if I open it, I know the approximate locations of the structures, but I feel like unless you're practicing it all the time and looking at it and really hammering your anatomy down, it's hard. So the things to look for on lateral radiographs. This is actually the right pulmonary artery, and I'll go into it in a second. So if you look at, I like this diagram. I kind of took it from a physician that teaches radiology on YouTube. I can send the link in the chat after. On the frontal view, yes, you can see the right diaphragm is higher than the left. The border of the heart is made up of from the right atrium on the right here, and then the left atrium, left ventricle on the left. And the mediastinal structures are always what get a little bit confusing. So the perihilar. So the lucency that goes down here, that's the trachea going down. I know it's not an ideal image, but I guess kind of like imagine it. And then you have your left main bronchus, right main bronchus, splitting into the left upper and left bronchus intermedius that continues on. And sort of sitting on top of it is the left pulmonary artery, and then the right pulmonary artery would be here. On the lateral, what you really want to focus on are sort of these midline structures. And they're a bit of a honestly, you kind of have to approximate it in your head, and that's how I think of it as well. So number one would be the trachea going down, and it splits into your left bronchus intermedius, right bronchus intermedius. Kind of can't tell from this projection, but if you look from kind of number four would be your right upper lobe bronchus, which is superior. It would be like lucency sitting right there. And then the number three would be the left the left upper lobe bronchus. So the right is always a little bit higher, and then the left is below it. And then number six, anterior to the trachea, that would be your right main pulmonary artery. And then behind the trachea over here would be the left main pulmonary artery. And that's generally typically the anatomy kind of this location here. So if you see like an abnormality, let's say of the six, that's kind of the right pulmonary artery is enlarged here, you can think of like pulmonary hypertension, right? So if we look at it here, it's kind of the trachea coming down, splitting. You have, if you convince yourself, the right and the left pulmonary bronchi, and then you have the right pulmonary artery and the left pulmonary artery behind it. I know it's a bit tricky, and I feel like lateral chest x-rays are something to get used to, and you have to look at them a lot, look at anatomy a lot to actually get used to what you're looking at. Okay. But why do we need them in like kind of our stage of training, medical school residency? I guess, especially if you're not planning to go into radiology, mostly to localize abnormalities. Okay. Okay. So case one. Do you guys want to take a stab? Does one of you want to take a stab at describing the abnormality? I know you guys sort of had the answers preemptively, but right? Is that correct?
Sort of, yeah. Like there was a little bit of walkthrough provided, but like not all the answers are given.
Okay. So let me know, what do you prefer? For me to kind of go through it, or do you want to take a stab at describing it and then I'll kind of continue going through it? Whatever you prefer.
I'd prefer if you walk us through it.
Perfect. Okay, so we have a 71-year-old guy, persistent right-sided chest pain, 30-pack year smoking history, weight loss, and you order this x-ray. And honestly, with regards to chest x-rays, everybody has their own approach. You had probably heard of like A, B, C, D, E, inward to outward, outward to inward. It doesn't matter what approach you use as long as you look at all the structures. I personally like to start at, like, I glance at it and quickly, and I see the abnormality, but I'm not going to start there because I'll likely miss a lot of the other things, right? Perhaps there's a bone lesion that I could miss because I fall into the bias of looking at this and only describing this. So I like to start at the mediastinal structures. I look at the trachea to see that it's midline. Sometimes you can see it a little bit deviated, and that's completely normal just because the aortic knob is sitting there. So I can actually just push it a little bit. So don't call it like a tension pneumo, for example. And then go down to look at the mediastinal contour, the heart contour. You're going to want to look for like cardiomegaly, for example. Next, I look at the perihilar structures, just to see if they're kind of enlarged, if there is any abnormality there. And then I zigzag quickly through the two lung fields to take a quick overview, and then I pay more attention to the lung fields, and now particularly concentrating on the abnormality, which I see here. And then I take a look at my soft tissues and bones. So I kind of go through vertebral bodies, go through the ribs quickly, go through the ribs on the other side, and then I take a look at the clavicles, and usually we see like the humerus can sometimes be present as well. And lastly, I take a look at all of my review areas. So these are the areas that we typically tend to miss when we look at a chest x-ray. So these are your apices to make sure there is no pneumo hiding there, no sort of apical mass. Next is the retrocardiac region, just because we tend to miss a lot of things hiding behind the heart that can kind of look like they're the heart, but they're not it's not just the heart. And then I take a look at my costophrenic angles, and lastly, anything subdiaphragmatic, which can tell us about something else going on with the patient. Okay, so in this chest x-ray, we see that in the right sort of upper zone, there's this fairly large radiodense structures, kind of well circumscribed on the bottom, but at the top, you can't really see the margins very well. And you have all of these parenchymal markings that are passing through it. You can't really tell, is it intraparenchymal? Is it extraparenchymal? It doesn't really have an appearance of a classic intraparenchymal lesion. You'd expect it to be a little bit more circumscribed, but can you really tell? Absolutely not. But this should be where your attention is drawn to. I know this chest x-ray looks a little bit messy with regards to the vascular markings, like let's say more messy than you would expect, but it's fairly normal. When you take a look at the lateral, this guy has a nicely relatively calcified aorta, but you see that this structure is up here. Okay, so that sort of confirms that this is not the right lower lobe, and I'll go into locations in 1 second. But you see how this structure doesn't really have very well-defined borders. If it was intraparenchymal, I'd again expect it to be sort of more well circumscribed. But yes, it is kind of attached to the anterior chest walls, if I'm using that terminology correctly. So this would raise your suspicion, and you'd be like, okay, I kind of weight loss, older gentleman, smoking history, I would probably want to do more imaging. Okay, so you would order a CT scan. When describing these lesions, we need to be able to localize them. And I'm sure you probably are aware of that, honestly, localization. And maybe I'm honing down on it. But I think it's important because sometimes we tend to get confused about localization, especially when we are only given a frontal chest x-ray. So when describing a pulmonary nodule or a pulmonary lesion, I should say, there are a few things that we should talk about and mention. So number one is the location. You want to say where it is, right upper lobe, right middle lobe, right lower lobe, etc. Okay, its size approximately. I know when you're reading a chest x-ray, you have the tools like on PACS to be able to actually measure it. Whereas if you're interpreting it in the clinic, you're kind of limited to what you see. But you would approximately be able to say, like, is it relatively small or is it relatively large? You want to describe the margins. So is it, actually, I have a thing there. So a nodule in technicality is 4 to 30 millimeters, so up to 3 centimeters. Anything that's larger than 3 centimeters is considered a mass. So in this case, what do you think? Is this 3 centimeters?
At least, right? It seems a bit larger.
Looks like a mass to me.
Yeah, so I would say this is definitely a mass. And then you want to describe the margins. Something that is smooth, and I'll give some examples of that a bit later on. Is it smooth? Is it spiculated? Can't really tell, like it kind of has all of these projections. So is it lobulated, or does it not have very well-defined margins? Presence of calcifications, that's kind of hard to tell on a chest x-ray, to be honest. Chest x-rays are not the greatest at picking up like intralesional calcifications. How do we tell if it's actually fully calcified? Well, it would be approximately the same density as bone, right? So if we see something that is kind of like the density of a clavicle, I have an example of that later on. It's like intrapulmonary right over here. It's kind of the same density. I'd be more inclined to say that it's likely calcified, but again, you can't actually be 100% certain. It can just be dense tissue. Does it have any air fluid levels within it or cavitations, which could narrow your diagnosis, differential diagnosis? And how stable is it? So you want to compare it with a previous chest x-ray. Was it there previously or not? If it's new, you're more suspicious of it being, let's say, like a malignancy, or and if the patient presented with infectious symptoms like a like a septic emboli, for example. Whereas if it's stable kind of there over time, you're more likely to say that it's benign. Okay. So when we talk about locations of lesions, we know that the right lung has the right upper, right middle, right lower lobe, and the left lung has the left upper lingula, left lower. And to be completely honest, you can't localize a lesion based on frontal radiograph alone, with some exceptions, and I'll go through that. And even then, you should question yourself. But if we actually think about the anatomy of the lungs, the right upper lobe, no, the left lobe, right, oh my gosh, right lower lobe, my brain, extends all the way up, right? If you remember the 3D anatomy, and let me actually share this with you. Okay, if you look at the anatomy of the lungs, the left and the right lower lobes are actually quite superior, right? So if you're looking at it on a chest X-ray, this region all the way up here can still be the right lower lobe, and this can be the left lower lobe. Okay, so you actually can't tell. So if you have a lesion over here, is it right upper, right middle, right lower? You can't be 100% certain. When you have your lateral, you can localize it with more certainty. Okay, this is your right middle lobe location, right lower lobe. So something that's over here, this is sort of, I know I'm saying that the right lower lobe extends all the way up to here. This diagram is showing that essentially if there is a lesion here, you can pretty confidently say that this is right lower lobe. Okay. This is your left upper lobe, and see it extends all the way down here. Okay. And your left lower lobe. And again, it can actually go all the way up here, but this is showing something that's exclusively limited to the left lower lobe. Okay, so when you're talking about differential diagnoses, overall, whether it be an intrapulmonary lesion, whether it's a lesion you see in the bone, whether it's a lesion you see in the abdomen on an abdo X-ray, CT, whatever, the kind of pathway that you should be going in your head, whether that is in radiology or whatever, is the same, right? You're thinking about a neoplastic process, you're thinking about an infectious process, an inflammatory process, a congenital process, a vascular process. If you're like internal, you can think endocrine process. So it kind of subcategorizes. And that way you'll be able to categorize your differential and correlate it with the patient's symptoms. So in this patient who had a smoking history, weight loss, you'd be more kind of leaning towards the neoplastic category. That's not to say there might be a second, like there's not a secondary process going on. So like maybe he has a malignancy elsewhere or whatever, or intentional weight loss, and has an inflammatory lesion, or he's quite sick. But you're kind of leaning towards this area here. Whereas like a child, for example, kind of relatively benign, you see a lesion, you might be thinking of something more congenital. And lupus, yes, health. Okay, what was I going on for here? Yeah, so when you see this lesion over here, this is just the same X-ray. Now that we know that the right upper lobe is kind of here on the lateral chest X-ray and occupying this region on the frontal, we can kind of pretty confidently say that it's in the location of the right upper lobe. Is it intrapulmonary or extrapulmonary? You don't know. You're going to order additional imaging anyways. For the sake of residency, for the sake of medical school, overnight, for example, on internal, if you have a chest X-ray, if you have a patient comes in, you get a chest X-ray done, the number one thing you have to be able to say overnight is, like, out of the things that could kill you, but not actually kill you, is there a pneumo? Things that will change your management right away. Is there a pneumo? Is there a pneumonia? And that's pretty much it, right? So the other things you probably want to get you probably want to get more imaging on it anyways. Okay. All right. And this is just to hone down what I went through with localizations. It's just the same link. So I'm going to show you some more cases, and this is mostly to see if you guys can localize the lesion, not necessarily nodules, but lesions overall. Okay. 1 second. Let me just make sure the quiz is back working. Okay. Where is the abnormality? Are you guys able to use Menti still?
Yes, we are.
Okay, perfect. Take your time. Perfect. So not sure, need more views. That's totally correct. So again, right field is kind of all over, right? So it might be actually a right lower lobe, kind of the superior segment of the right lower lobe. You need a lateral view to be able to characterize it better. Great. And that is totally the abnormality. Okay, what about this? This one's maybe a bit more tough. And I'll tell you that this is not a nodule. Yeah, that's totally correct. This is left lower lobe atelectasis. You see kind of complete obscuration of the diaphragm, right? The ribs here look crowded. Can't really define like the end of the hard beginning of the diaphragm too well. And we know that the left lower lobe sits here. So this is collapse of partial collapse, or actually full collapse of the left lower lobe. Great. Okay, where is that abnormality? Well, okay. Not sure I need more views. I agree. I would ask for a lateral in this case as well. But in this case, I'd be more inclined to say, and I might be wrong, honestly. I'd be more inclined to say that this is left lower lobe. And the reason is because it's retrocardiac. It's not obscuring the heart. You see it kind of well aligned. Yeah, I know that the lingula is over here, but if it was a lingular lesion, I would expect it to not be as well visualized. It sort of be kind of together with the morphing into the heart, kind of abutting it. So this is probably left lower lobe, but I agree. I would probably ask for an additional lateral view. If you actually, what I like doing with chest X-rays, and this is just like a little tip, is when you're reading it, it doesn't matter, you don't need PACS to do this, just invert the image and it actually highlights some abnormalities better. So like in this case, you see the nodule much better than you do here. It also looks, that looks a little bit funky. But pneumothoraces as well are actually, I find them easier to spot on this inverted view.
So quick question, Maria.
Yeah.
How do you know, like you said, it's retrocardiac, right?
Yeah.
How do you know it's retrocardiac? How do you know it's not like in the chest wall or something like that?
Well, good question. I actually don't. It might be abutting the chest wall. It might be like intraparenchymal.
Okay.
I can honestly, I wish I could tell you. I don't think I have the knowledge myself to get
Is that just
to like say that
just,
confidently.
Okay. It's like is it like a gestalt thing? Like you just kind of get a sense for where things are in terms of retrocardiac and
Yeah, I guess more so I honestly, I feel like if it was extra parenchymal, it would kind of be more at the periphery,
Okay.
and kind of not as well defined with its borders.
Okay. So the nature of the lesion kind of gives you clues about that. Okay.
Yeah.
That's great.
I kind of agree, but my reasoning is that in the bottom right corner it says retrocardiac flow nodules.
Is that Nav?
Yeah, that's me.
Oh, okay. Yeah. Okay. Mostly, yeah, extraparenchymal lesions typically are kind of not as well circumscribed from my understanding. Okay. I can totally get back to you about that, because honestly, sometimes I'm confused about them myself. I should not be saying that. This is evidence going on to YouTube.
I'll cut this part out. I'll cut it.
No problem. I don't care. PGY1, ask stupid questions. Okay. And I think that's probably the last one. Well, where is the abnormality? This one's a bit more subtle, but I liked it. A good one. Does that change your answer? Okay. Are you able to see the lateral and the frontal view?
Yes, we are.
Okay, so this is a patient with, this is a follow-up x-ray of a patient who had previous septic emboli. And now we see this sort of well-circumscribed lesion in the, how I would describe it. If I only had a frontal x-ray, I would describe it as a well-circumscribed lesion with a central lucency in the left upper periphery, kind of periphery of the left upper lung zone. But I'm not sure, is it the left upper lobe or is it the left lower lobe? Because when you look at the lateral x-ray, the lesion is right over here, okay? So we know that this section is occupied by the lower lobe of the left lung. So this can't be left upper, because if it was left upper, you'd see it up here. You're seeing it up here. This is a left lower lobe nodule that's actually quite high. So these things are tricky. Okay. And last case. And then I'll stop torturing you with these. Oh, there you go. %, agree. You need more views. So this is the abnormality, a well-circumscribed kind of radiodense lesion in the periphery, in the right lower zone of the lung. Okay. Can't really tell, is it left lower? Well, you're more likely to say that it's, right lower, more likely to say that it's right lower. It might be right middle, but it's probably right lower. I would get a lateral view. This ended up being a patient's nipple. So just keep that in mind, something that looks well circumscribed, especially if it's bilateral, that is probably a patient's nipple. And I've had a case like that where I thought it was like a lesion, but it was just a nipple. Okay, so that being said, the point of all of this is just to be able to localize. Just remember that right upper is up here, but the right lower also can extend up here. So anything over here can either be right upper, right middle, or right lower. And you need a lateral view to confirm. And kind of same thing with the left. Anything up here, you'd expect it to be left upper, but the left lower can also extend all the way up here. You can use your secondary signs like silhouetting signs, etc. And that's more so for like pneumonias. So for example, if you would see obscuration of the left heart border, you're more likely to say that it's a lingular lesion as opposed to a lower lobe. Because if you had, let's say, like a pacification over here, but you can still see the heart border, that means the kind of, there's like, if you think of it about 3D, the opacity is actually posterior to it. Otherwise, you can't see the heart border. But anyways, that's another talk. So you can rely on your secondary signs, but with nodules specifically, you need further characterization, probably with like a lateral X-ray and then follow-up imaging if you're concerned about a malignancy. Okay. Case number 2. So this is kind of also my goal is to be able to describe this, okay, with you guys, for you to be able to describe this at the end of the talk. So again, going through my pattern, I look at the mediastinum, the mediastinal structures, scan through the lung field, going up, going down. I see this, I will stop here. Don't get the satisfaction of search. I kind of look through the bones, scanning that way and that way. And then finally, again, the review areas, the lung apices, retrocardiac position, costophrenic angles, and anything subdiaphragmatic. So in this case, we have pretty relatively well circumscribed lesion. You can't really tell the left border of it very well, but it's kind of dense. And you see that there are these kind of structures that are extending to it from your left hilum, which is not what you see typically, right? And it's likely in the left lower lobe. It's not really obscuring the heart border. It's not giving you like a silhouette sign of the left heart border. So this is kind of making me say that even if I didn't have the lateral, I would probably still say left lower lobe lesion. Why? Because you're not having silhouetting of the left heart border. So this is kind of inclining you to say that this is the left lower lobe. And again, if you look at the lateral, this is where your left lower lobe is. And indeed, it is within the expected zone of the left lower lobe. So this is a left lower lobe lesion. And if you look at a normal X-ray, we don't really have things that are so kind of the same, what am I saying? Hyperdense, running through the heart. There are some vessels, but this is a bit too thick to be a regular vessel, okay? So that's making me think that there is some sort of communication going on here, okay? And indeed, this turned out to be an arteriovenous malformation. Okay, and arteriovenous malformation typically are within the lower zones of the lung, and patients usually present with hemoptysis. Sometimes they can present with shortness of breath, but hemoptysis is usually the main presenting complaint. This is just an X-ray done with dye, essentially, where they inject dye and then they take a picture. And you can see these communicating channels going from the lesion into the lesion, which would kind of incline you to say that this is likely some sort of vascular malformation going on. In general, you're going to need a CT to characterize this better. You're not going to reach that diagnosis in a chest X-ray, so you'll need to inevitably do a CT scan to see what the heck is going on within this patient's lung fields. And yeah, again, these are the vascular structures that are extending to this lesion. And if you do a CT, this is a CT of a patient with an arteriovenous shunt fistula, and we see that there is kind of pulmonary arteries and pulmonary veins pulmonary arteries and pulmonary veins going to and from the lesion over here. And then it was a girl with, I think, I can't remember, she had a syndrome. But all in all, the point of this case for me was not to be, to kind of tell you that, oh, these are things you should know in terms of your differentials, because to be honest, it's relatively uncommon, okay, compared to your like run-of-the-mill things. But I think the main learning point from this case was to be able to localize and describe this lesion, and to be able to see that there is abnormality leading to the lesion itself, with like vascular structures going to it. And this is just another case of arteriovenous fistulas that I found. This was a retrocardiac density. So again, if you look at, you're doing your search, you grade whatever, you do everything thoroughly, and then you do your review areas, you look at the apices, and then you're like, oh, what is this going on here? Okay, that doesn't really look like a regular heart, right? If you take a look at the heart in this picture, okay, with the where's a normal heart? Oh yeah, this picture. It's kind of the same density throughout, right? This is not. This looks like there's some worms right over here. That's funky, okay? And then if you look at, this is actually, I believe this is the same patient. Anyways, yeah, the same patient. And there is some elevation of the right diaphragm, sort of behind the diaphragm, that also looks a little funky. So it ended up being two arteriovenous malformations, one here and then one here. And again, CT is going to be your key to characterize this better. And usually we coil these patients and then they end up doing fine. But yes, again, take home point is, I did not mean to scroll through that. I don't know where my slide went, but characterizing lesions is important. Describing them, like with your, how to describe them is talk about location, talk about the size, talk about margins of the lesion, whether it has calcifications present, whether it has any cavitations or air fluid levels, and how it compared to the previous x-ray. And then that's going to kind of help you narrow down your differential diagnosis. But again, at this stage, I think the primary thing for you to be able to do is to be able to describe the location of the lesion and characterize it, and just use your descriptive terms, because differential diagnoses, I think, will come with time. Just can't possibly know it all right away. I think that is it. Hold on.
Thank you so much. That was outstanding. I really appreciated the interactive element, the Mentimeter, and just how most of these sessions are kind of just a walkthrough of the case, but you really like brought out central concepts and like important points for learning. So that was very effective. Yeah.
You're flattering me. And honestly,
I know you has been here in the past, and I'm sure he would agree. Yeah. So
I totally agree. Yeah.
Yeah. It was wonderful.
Thanks, guys.
So yeah, does anyone have any questions for Maria?
I guess I can go first. Do you have any resources that you think would be helpful for us, like as medical students, to kind of learn normal anatomy and like, get like the basics down for x-rays, maybe like general CT things?
Yeah, I can send David some links from YouTube that I really liked. So I used those, and there's like Radiology Assistant, has a few things about chest x-rays. I think what I personally did in med school is like on rotations is I looked at those videos. And what else did I do? And then kind of just get in the habit of looking at all the imaging that gets done on your patients to be able to see like normal versus abnormal. I think that's the number one thing, to be able to like pick up abnormal anatomy and be able to see as many normal things as possible. Because it's easy well, it's easy. It's easier to identify abnormalities when you actually have seen a lot of these normal cases. So if you are interested in radiology, and even if you're not interested in radiology, I think it's just very vital to kind of look at as much imaging as possible, because inevitably you're going to encounter it, whatever specialty you go to. Even if you decide to go into like pathology, they still look at imaging. Yeah. I'll send David the links, and then he can share it with you guys.
Yeah, I'll get those out to the class via Facebook. That's great.
And I guess just a follow-up question, you kind of touched on it already, but like the expectations during rotations, like say you do an elective in radiology, like at a med student level, maybe like second or third year, and when you're there, what are the expectations like in terms of like what you need to know?
Yeah, Maria will just grill you. She's
I'm terrible. I'm so harsh. Honestly, I think like no expectations, truly. I think if you're interested in radiology, to be honest, you're sitting with the residents mostly. Just have an open mindset and like ask questions. No questions or too many questions. Like obviously, if you feel like the resident is kind of falling behind with volume, and you're like asking questions every 2 seconds, like I doesn't matter to me, but others might mind it. I know like our resident group is absolutely fantastic. But I think have an open mindset, like when you come to the radiology elective, just know your basic anatomy. Typically people ask like bones of the hand, bones of the foot. What is this on a chest x-ray? So be able to know those things, and then you're good. Honestly, during my radiology electives, I had zero interaction with staff. It was terrible. Yeah.
Hopefully it's better for us. Fingers crossed.
Yeah, you end up, you'll see us. You'll probably mostly see us. Which is fine, because like, I know reference letters are stressful, but just if you are like hoping to go into radiology, you can always ask the residents like, oh, I'm interested in radiology, like blah, blah, blah. And can I maybe see if I can follow the staff, where I heard community rotations are really good for the radiology reference letters. But I don't know. It was different. Like for me, it was different in Ottawa compared to you guys here.
That's true. I'll just like double down on that statement that here, the one we did at St. Joe's, I was with Maria and a few of the other residents. I think I had 1 day with staff over 2 weeks.
Yeah.
But then I did a community elective in Niagara, and it was with staff every day for 2 weeks. So, but the residents are much better at teaching. Like you get a lot more teaching from residents. But if what you want is a letter, definitely try to do Niagara or Waterloo.
Okay.
Yeah, like we didn't have a community option in Ottawa. It was just teaching hospital, and it was really bad. Like for people that wanted to do radiology but didn't have, let's say, any research with it, like adult radiologists, you couldn't actually get enough interaction to get a good letter. So yeah, it was tough. I'm sorry if I didn't answer all of your retrocardiac questions, but
No, you had a great answer. So does anyone have any final questions for Maria before we let her go?
I think that's it for me.
Okay, sounds good. Thanks for showing up. I'm sorry I'm not as entertaining as Love is Blind on Netflix, but you can go back to that if you'd like.
Well, thank you so much for coming, Maria. It was a real pleasure. I really enjoyed the presentation. So thanks again.
Yeah, no problem. I'll send you the links, David.
Perfect. And I'll get those out to everyone else. Okay.
Perfect.
Thank you
Have
so
a
much.
good call shift.
Thank you. Yeah. Thank you. 18 hours to go or something like that. So yeah. Okay.
Oh, it's
Take
tough.
care.
Are you also on a call? No, now are you wearing scrubs?
No, I'm wearing scrubs, but this is just the life of me now. I'm always wearing scrubs.
Yeah, okay. Okay, bye guys.
See ya.
Okay. Take care.